Welcome. In this session, we are going to start our discussion on intraocular tumors, and in this session, we are going to take up retinoblastoma. From this session onwards, we'll have a recap section at the very end of the video to summarize and highlight the main points of the topic. Retinoblastoma arises from malignant transformation of immature differentiating retinal cells, also known as retinoblasts, in the developing retina of a young child. But after a certain age, following complete development of the retina, these retinoblasts fully differentiate to mature retinal cells and no longer divide, and thus following that age, they are no longer able to give rise to retinoblastoma tumors. So vast majority of retinoblastoma tumors occur before 6 years of age. Retinoblastoma is the most common primary intraocular malignant tumor in children, and it is the second most common primary intraocular malignant tumor in all age groups. When all age groups are considered, uveal melanoma is the most common primary intraocular malignant tumor. Retinoblastoma affects all races and both sexes, and lifetime incidence of retinoblastoma is estimated to be 1 in 14,000 to 20,000 individuals. India has the highest incidence of retinoblastoma with more than 2,000 new cases per year, followed by China with more than 1,000 new cases per year. Bilateral retinoblastoma patients constitutes 1/3 of all retinoblastoma cases, and 90% of all retinoblastoma patients present before 3 years of age. The mean age of presentation of retinoblastoma patients depend on the heritability of the tumor. Patients with a positive known family history undergoing routine surveillance for retinoblastoma have a mean age of presentation of 4 to 8 months. Patients with bilateral retinoblastoma without a known positive family history have a mean age of presentation of 12 months, and unilateral retinoblastoma patients have a mean age of presentation of 24 months. Before we discuss the clinical features, diagnostics and treatment modalities of retinoblastoma, we'll discuss the genetics of retinoblastoma and genetic counseling, which goes hand in hand with genetics. 97 to 99% of all retinoblastoma cases occur due to a loss of function mutation in both the alleles of the retinoblastoma or the RB1 gene in a single differentiating retinal cell. The RB1 gene is autosomal recessive in nature and is located in the long arm of chromosome 13. So a mutation in both the alleles of the retinoblastoma gene in a single and the same differentiating retinal cell is essential for the retinoblastoma tumor to occur, and this is very important to remember and is known as the two-hit hypothesis. The normal RB1 gene being a tumor suppressor gene, its protein product prevents progression of the cell cycle. So mutation in the retinoblastoma gene not only causes retinoblastoma but also causes other tumors, as we will be discussing. So for non-hereditary retinoblastoma to occur, both the alleles of the retinoblastoma gene, which were originally normal when inherited, has to acquire mutation in a single differentiating retinal cell, and the chance of that happening in a single differentiating retinal cell is quite low. As a result, non-hereditary retinoblastoma presents as unilateral unifocal tumors. Whereas in hereditary retinoblastoma patients, one allele of the retinoblastoma gene is already mutated in all cells of the body, including all differentiating retinal cell. So for a retinoblastoma tumor to occur in hereditary retinoblastoma patients, only the remaining normal allele needs to acquire a mutation in a single differentiating retinal cell. So the chance of a single differentiating retinal cell in hereditary retinoblastoma patients to acquire mutation in the remaining normal allele of the retinoblastoma gene, leading to both alleles becoming mutated, is higher than the chance of a single differentiating retinal cell in non-hereditary retinoblastoma patients to acquire mutation in both the normal alleles of the retinoblastoma gene. And so this single mutation can occur in multiple differentiating retinal cells in hereditary retinoblastoma patients, resulting in hereditary retinoblastoma patients presenting with bilateral multifocal tumors. Mutation analysis of the retinoblastoma gene can be done with peripheral leukocytes or with enucleated retinoblastoma tumor specimen when available. Mutation analysis helps in determining the risk of future retinoblastoma tumors occurring or second primaries occurring in the affected patient. We'll be discussing about second primaries later in this session. Mutation analysis also helps in determining the risk of retinoblastoma occurring in siblings and offspring of the affected patient. Pre-implantation diagnosis and in vitro fertilization techniques to select embryos without the mutation are also available. 10% or a minority of all retinoblastoma patients have a known positive family history of retinoblastoma occurring in parents, siblings, first or second degree relatives, and these are known as familial cases of retinoblastoma, and they have an inherited mutation of one allele of the retinoblastoma gene in all cells of the body, and as a result have bilateral and multifocal tumors as we have discussed, and they pass on this retinoblastoma trait to their next generation. 90% or the majority of all retinoblastoma patients do not have a known positive family history, and they are labeled as sporadic cases of retinoblastoma. 2/3 or a majority of these sporadic retinoblastoma patients occur due to somatic mutation in both alleles in a single differentiating retinal cell, and thus typically have an unilateral solitary tumor as we have discussed, and they do not pass on this retinoblastoma trait to their next generation. However, 1/3 of sporadic retinoblastoma patients occur due to either a new germline mutation in a single allele of the RB1 gene. As a result, there is a mutation in a single allele of the RB1 gene present in all cells of the body, including all differentiating retinal cells, and thus they also have bilateral and multifocal retinoblastoma as we have discussed. And these sporadic retinoblastoma patients with a new germline mutation, although they do not have any positive family history of retinoblastoma, they do pass on this retinoblastoma trait to their next generation. Some cases with multiple and bilateral tumors occur due to mutation happening during embryogenesis, and in these patients some but not all cells in the body have a mutation in a single RB1 gene, and they are known as mosaics. These patients may or may not pass on their retinoblastoma trait to their next generation depending on the stage of embryogenesis during which the mutation in the retinoblastoma gene occurred. So familial retinoblastoma patients constituting 10% of all retinoblastoma cases, and sporadic retinoblastoma patients with a new germline mutation or mosaicism constituting 1/3 of the remaining 90% of all retinoblastoma cases, thus tend to have multifocal and bilateral tumors with an earlier presentation as we have discussed. However, it is important to remember that not all unilateral unifocal retinoblastoma cases are due to somatic mutation. 15% of all unilateral and unifocal retinoblastoma patients do have a germline mutation, and this is why genetic testing for mutations in the retinoblastoma gene is recommended for all retinoblastoma patients, irrespective of whether they have unilateral unifocal tumors or bilateral multifocal tumors. Up to 3% of all retinoblastoma patients are due to amplification or increase in the number of copies of NMYC proto-oncogene, and not due to a mutation in the retinoblastoma gene. They present before 6 months of age and usually have a non-hereditary and unilateral disease. The disease is clinically similar to an RB1 mutation retinoblastoma but behave more aggressively. However, histopathologically they are different, having undifferentiated cells with prominent and multiple nucleoli, little calcification, and without flexner intestinal rosettes or nuclear molding, as we will be discussing. The eye having retinoblastoma due to amplification of the NMYC proto-oncogene should be enucleated. All family members, including parents and siblings of all retinoblastoma cases, should be examined. Retinocytomas, which we will be discussing in this session, can be found in parents of 1% of all retinoblastoma cases, and untreated retinoblastomas can be found in siblings of retinoblastoma patients, and both these will signify familial or heritable disease. Inherited mutated RB1 allele has 90% penetrance. So far as siblings of the retinoblastoma patient are considered, unaffected parents of a single child with bilateral retinoblastoma have less than 5% risk of their next child having retinoblastoma. But unaffected parents with 2 or more affected children have a 45% risk of their next child having retinoblastoma. And so far as offspring of retinoblastoma patients are considered, offspring of a survivor of bilateral retinoblastoma have a 45% chance of having retinoblastoma. But for a survivor of unilateral retinoblastoma in whom genetic mutational analysis has not been done, the chance of his or her offspring having retinoblastoma is 7 to 15%. Presenting clinical features of retinoblastoma depend on whether the patient presents at an early stage or a later stage in the disease process. Early stage presentation usually occurs in developed countries, and parents of these patients usually complain of leukocoria or a white pupillary reflex as seen in this photograph, also known as cat's eye reflex. And this is the most common presenting symptom of early retinoblastoma. Strabismus is the second most common presenting symptom of early retinoblastoma, and in this photograph we also find strabismus. So leukocoria and strabismus are early presenting features of retinoblastoma and are very important to remember. Late presentations usually occur in underdeveloped countries, and the parents usually complain of signs and symptoms of orbital inflammation as seen in this photograph and proptosis. Other signs which the parents may notice in a later stage of the disease process includes iris heterochromia, pseudohypopyon, and spontaneous hyphema. On examination, early tumors are usually seen in patients with a known positive family history undergoing routine surveillance for retinoblastoma, and these early tumors appear as a round translucent greyish-white mass within the retina. In this photograph, we see such an early tumor beside a larger retinoblastoma tumor. Later stage tumors present as a chalky white mass due to calcification within necrotic foci, and we'll also find dilated tortuous feeder and drainer retinal vessels. Surface capillary telangiectasia may also be there, making the tumor appear pinkish. Surrounding cuff of serous retinal detachment can be found surrounding the base of the tumor and is a very important sign for grading the tumor. Seeding, that is detached fragments of the tumor, can be found in the vitreous cavity and subretinal space, and these are also a very important sign for grading the tumor. So here in this photograph we find a peripheral retinoblastoma with early vitreous seeding, and in this photograph we find a relatively large retinoblastoma tumor which has ruptured through the internal limiting membrane into the vitreous cavity with vitreous seeds. Massive tumors defined as more than 15 mm in basal diameter show two types of growth pattern. In the exophytic growth pattern, the tumor grows within the subretinal space, and we'll find subretinal seeds which may give rise to new tumor foci. And the new tumors arising from these subretinal seeds may be difficult to distinguish from multiple primary tumors which have genetic implications. Subretinal fluid accumulation occurs in exophytic tumor growth pattern, leading to an exudative retinal detachment which may obscure the visibility of the tumor. In the endophytic growth pattern, the tumor grows along the retina and into the vitreous cavity. Vitreous seeds will be found which may give rise to new tumor foci, and these vitreous seeds may migrate into the anterior chamber and present as iris nodules and pseudohypopyon. When the endophytic tumor becomes big enough, it obscures the visibility of the retina. Most advanced tumors have both exophytic and endophytic components, and the view of the underlying tumor may be obscured by either extensive vitreous seeding in endophytic tumors or by turbid subretinal fluid from extensive subretinal seeding in exophytic tumors. Other signs which may be found in a patient with a late presentation include iris neovascularization, which can lead to iris heterochromia or secondary glaucoma, spontaneous hyphema, pseudohypopyon as seen in this photograph. Pseudohypopyons are white in color and moves with change in position of the patient's head. Anterior chamber seeding as seen here in this photograph, leading to iris nodules. Vitreous hemorrhage, orbital inflammation as seen here in this photograph, proptosis due to extraocular extension of the tumor posterior to the globe in the orbit, and pinealoblastoma, which occurs in 5 to 15% of patients with bilateral and familial retinoblastoma, and which we will be discussing in this session. Modes of spread of retinoblastoma include neural spread through the optic nerve into the cerebrospinal fluid, hematogenous spread through the choroid to distant sites in the body, lymphatic spread through anterior chamber angle and conjunctival lymphatics to preauricular and cervical lymph nodes, and local extraocular spread through the sclera into the orbit. Common sites of spread of retinoblastoma include orbit, brain. Brain is the most common distal metastatic site of retinoblastoma and also the site with the poorest prognosis for the patient. Distal bones, lymph nodes, skull bones, spinal cord, and abdominal viscera. Diffuse infiltrating retinoblastoma is a rare variant of retinoblastoma which can be mistaken as intraocular inflammation and thus is considered among the masquerade syndromes of uveitis. Diffuse infiltrating retinoblastoma usually occurs unilaterally in older children with the usual age of presentation being more than 5 years and predominantly occurs in male patients. It usually presents as vitreous opacities and may have pseudohypopyon. The vitreous opacities occur in clumps of various sizes, unlike vitreous cells where the opacities are uniform in size, thus helping to differentiate diffuse infiltrating retinoblastoma from uveitis. Diffuse infiltrating retinoblastoma may present with a diffuse fluffy infiltration of the retina appearing white in color without any discrete retinal tumor being seen, and diffuse infiltrating retinoblastoma also does not show any calcification, which makes it more difficult to diagnose. Diagnosis of retinoblastoma is mainly clinical, supported by imaging studies. Standard fine needle aspiration biopsy is contraindicated in suspected retinoblastoma cases because it may cause extraocular spread. This is in contrast to choroidal melanoma, where fine needle aspiration biopsy is often done in diagnostic dilemmas. With diagnostic dilemma in a patient with a good visual potential, FNAB through clear cornea followed by cryotherapy can be considered, but is done only very rarely. Examination under anesthesia or EUA is mandatory for all patients suspected of having retinoblastoma. EUA helps us in determining the number, location and size of the tumor masses, detecting subretinal and vitreous seeding, subretinal fluid, anterior segment involvement and iris neovascularization. All these factors help us in grading the tumor and prognosticating for the patient. Corneal diameter and intraocular pressure should also be measured during the EUA. During EUA, both the eyes should be examined with their pupils dilated even if the disease is apparently unilateral, and multiple EUA sessions may be required for a single patient for treatment, monitoring progress, detection of tumor recurrence, and detection of new tumors in bilateral or familial cases. Certain diagnostic procedures can be done during the EUA with handheld equipment being available nowadays. Fundus photography is important for monitoring and recording the progression of the disease and its response to therapy. Fundus fluorescent angiography done with handheld equipment during EUA may show dilated feeder vessels, capillary telangiectasia, intratumoral vascular leakage, retinal venous leakage, and iris neovascularization. OCT done with handheld equipment during examination under anesthesia will show small tumors as spherical isodense homogeneous masses arising from the outer nuclear layer or from the outer nuclear layer and the inner nuclear layer. Please see a photograph on the internet, as I have not been able to find a non-copyrighted image. OCT may also help us to image vitreous seeds, which may appear cystic, and may help us to pick up very small ophthalmoscopically invisible tumors. Ultrasonography is an essential diagnostic modality for patients suspected of having retinoblastoma and is particularly useful when view of the presumed tumor is inadequate. The tumor shows up as a dome-shaped mass with intralesional scattered hyperreflective foci representing calcification, which is characteristic and almost pathognomonic of retinoblastoma, and this is very important to remember. This photograph shows a tumor with almost confluent calcification. As we have mentioned, ultrasound helps in detecting tumor mass in eyes with dense vitreous and subretinal seeding obscuring the view of the tumor. However, in eyes with very large tumor with extensive calcification, ultrasound may not be able to assess or image the optic nerve and orbit to determine their involvement by the tumor. On ultrasonography, diffuse infiltrating retinoblastoma neither shows a discrete retinal mass nor any calcification, and thus are difficult to diagnose. Magnetic resonance imaging is recommended for all retinoblastoma patients, and it is better than CT scan in soft tissue resolution. What is more important is that it is safer than CT scan by avoiding exposure to radiation in patients with familial and bilateral tumors who are genetically predisposed to developing cancers. MRI can detect the intraocular tumor, extrascleral orbital extension, and involvement of the optic nerve and the central nervous system. In this photograph, MRI shows optic nerve involvement, and in this photograph, the MRI shows orbital involvement. Metastatic workup with bone marrow biopsy and lumbar puncture is indicated in patients with evidence of extraocular spread, either local or distant, and in patients with neurological abnormalities. Differential diagnosis of retinoblastoma, or more specifically leukocoria, are very important. Among them we have persistent fetal vasculature, previously known as persistent hyperplastic primary vitreous, the most severe form of which can present with leukocoria within the first few weeks of birth. Anterior segment examination usually reveals a fibrovascular proliferation posterior to the posterior capsule of the crystalline lens, which usually draws the ciliary processes inwards. Along with that, there can be microphthalmia, shallow or flat anterior chamber, hypoplastic iris with prominent vessels, and cataract. On ophthalmoscopic examination, we will find a stalk or its remnants extending from the optic nerve to the posterior capsule of the crystalline lens with or without a closed funnel retinal detachment. Small foci of calcification may also be present in persistent fetal vasculature. Coats disease is an unilateral entity presenting usually in the first decade of life, with the most common age of onset being within 6 to 8 years, and predominantly affects males. On examination, we will find retinal telangiectasia with intraretinal and subretinal yellowish exudation without a discrete mass lesion. Fundus fluorescent angiography shows telangiectatic vessels with associated retinal ischemia, and ultrasound shows subretinal deposits which are made of cholesterol, but there is no evidence of calcification. Ocular toxocariasis also comes in the differential diagnosis of leukocoria, and ocular toxocariasis occurs in older children who are exposed to soil or kittens and puppies. Ocular toxocariasis usually presents with posterior or peripheral granuloma with or without evidence of active intraocular inflammation. In this photograph, we find peripheral granuloma and posterior peripapillary granuloma in a patient with ocular toxocariasis. Associated exudative retinal detachment, vitreoretinal traction, and cataract can also be present. However, ultrasonography does not show any evidence of calcification. Astrocytomas can also present as leukocoria, and they are glistening white tumors which may be single or multiple and can occur unilaterally or bilaterally. They may enlarge and calcify with a lobulated appearance called mulberry tumors. Most astrocytomas are isolated and are not associated with any systemic disease, but some of them can be associated with diseases such as tuberous sclerosis or neurofibromatosis. Optical coherence tomography shows the tumor to be arising from the nerve fiber layer, in contrast to early retinoblastoma, which appears to arise from the outer nuclear layer. Medalloepithelioma also comes under differential diagnosis of leukocoria, and they usually present between 4 to 12 years of age as an off-white to cream-colored lesion, mostly arising from the ciliary body, but rarely they can arise from the retina or the optic nerve. They can present with iris heterochromia and iris neovascularization without an apparent cause, or can invade the anterior chamber when the tumor will be visible in the anterior chamber. Imaging shows large cysts on the surface of the tumor and also within the tumor. Medulloepitheliomas are mostly benign, but they can also be malignant, and they should be either observed or removed by enucleation. Excision of medulloepithelioma tumors are not recommended because that leads to destruction of the globe. Other causes of leukocoria which comes under the differential diagnosis of retinoblastoma include cataract, organizing vitreous hemorrhage, retinal detachment, uveitis, myelinated nerve fibers, myopic retinal degeneration, choroidal and or optic nerve coloboma, familial exudative vitreoretinopathy, and retinopathy of prematurity. A white reflex in a child's pupil may appear as an artifact in a photograph. Three staging classification systems of retinoblastoma need discussion: Rees-Ellsworth, IIRC, and AJCC systems. Rees-Ellsworth system was one of the earliest staging classification systems for retinoblastoma, and it stages the intraocular extent of the disease based on number, location, and size of the tumor. Rees-Ellsworth system prognosticates the chances of globe preservation following external beam radiation therapy and classifies the tumors into 5 groups, with the response of group 1 to EBRT being very favorable and the response of group 5 tumors to EBRT being very unfavorable. Rees-Ellsworth system does not stage extraocular disease, does not prognosticate chance of survival for the patient or preservation of vision following external beam radiation therapy, and does not prognosticate outcome following chemotherapy, which has now become the cornerstone of therapy for retinoblastoma. Since external beam radiation therapy has fallen out of favor for treatment of retinoblastoma, Rees-Ellsworth system is no longer used in most centers across the globe. The IIRC, or the International Intraocular Retinoblastoma Classification System, is presently the most commonly used system, and it also stages the intraocular disease based on size and location of the tumor, presence of subretinal fluid, and presence of subretinal and vitreous seeding. We may note here that it does not consider the number of tumors for grading the tumors. IIRC system prognosticates globe salvageability or preservation following systemic chemotherapy along with local consolidation therapy, and classifies eyes with retinoblastoma tumor into 5 groups, with group A being most salvageable and group E being least salvageable following systemic chemotherapy along with local consolidation therapy. Tumors confined to the retina with a size less than 3 mm and located more than 3 mm from the fovea and more than 1.5 mm from the optic disc are classified as group A tumors. There should be no vitreous or subretinal seeding for the tumor to be classified as a group A tumor. Tumor of any size and location not meeting criteria of group A are classified as group B tumors, but they should not have more than 5 mm subretinal fluid from their base, and they also should not have any vitreous or subretinal seeding. Tumors having focal vitreous and subretinal seeding and tumors having subretinal fluid involving up to 1/4 of the retina are classified as group C tumors. And tumors with diffuse vitreous and subretinal seeding and tumors with subretinal fluid extending for more than 1/4 of the retina are classified as group D tumors. Massive non-discrete exophytic or endophytic disease is also included in group D. Retinoblastoma tumors destroying the globe structurally and functionally are classified as group E tumors, and these eyes show either irreversible neovascular glaucoma, massive intraocular hemorrhage, orbital cellulitis, or phthisis. Tumors touching the posterior capsule of the lens or spreading to the anterior segment are also classified as group E tumors, and so is diffuse infiltrating retinoblastoma. The 8th edition of AJCC, or the American Joint Committee on Cancer, or the TNM system, classifies retinoblastoma based on extent of the ocular disease, lymph node involvement, distant metastasis, and heritability of the tumor. In the AJCC system, the primary intraocular tumor is classified as T1, T2, T3, or T4. In the CT1 or the intraretinal tumor, subretinal fluid extends less than 5 mm from the base of any of the tumors, with CT1A being tumors less than 3 mm in size and further than 1.5 mm from the fovea and the disc, and CT1 being tumors more than 3 mm in size and or located nearer than 1.5 mm from the fovea or the optic disc. The tumor is classified as CT2 or intraocular when there is subretinal fluid extending more than 5 mm from the base of any of the tumors when it is classified as CT2A, or if there is presence of subretinal or vitreous seeding when it is classified as CT2B. The primary tumor is classified as CT3 or advanced intraocular disease when there is either phthisis or prethisis, invasion of uvea or anterior segment, iris neovascularization or raised intraocular pressure, hyphema or massive vitreous hemorrhage, or aseptic orbital cellulitis. The primary tumor is classified as CT4 or extraocular disease when there is radiological evidence of involvement of the retrobulbar optic nerve and or the orbit, and then it is designated as CT4A, or when there is clinically evident proptosis and or orbital mass when it is designated as CT4B. Lymph node status is designated as N1 when there is involvement of preauricular, submandibular and or cervical lymph nodes, and metastasis status is designated as CM1A when there is involvement of distant sites such as bone marrow and abdominal viscera either clinically or radiologically, and is designated as CM1B when there is radiological evidence of central nervous system involvement. However, it is important to remember that trilateral retinoblastoma or pinealoblastoma is not considered as a metastasis, which we will be discussing shortly. Heritability status is designated as H0 when both the RB1 alleles are normal in extraocular tissues. It is designated as H1 in bilateral retinoblastoma patients, trilateral retinoblastoma patients, patients with family history of retinoblastoma, or in patients in whom mutation analysis has shown mutation in the retinoblastoma gene. Heritability status is designated as HX when there is insufficient evidence of heritability, particularly in patients with unilateral retinoblastoma in whom genetic analysis has not been done. Histopathology of retinoblastoma tumors on hematoxylin eosin staining typically shows three areas. The tumor cells appear blue, areas of necrosis appear pink, and areas of calcification appear purple. Tumor cells have large hyperchromatic nuclei with a high mitotic index and with scant cytoplasm. Close packing of cells cause indentation of their nuclei, which is known as nuclear molding. Viable cells are located adjacent to blood vessels, and this arrangement of viable cells around blood vessels is called pseudorosettes. 90 to 120 micron away from the blood vessels, areas of necrosis are found, as seen here in this photograph, and subsequently calcification occurs in these necrotic areas. DNA of the degenerated tumor cells deposit in the walls of the blood vessels, causing basophilic staining of the blood vessel walls. Signs of retinal differentiation of tumor cells in retinoblastoma include Flexner-Winter-Steiner rosettes, Homer-Wright rosettes, and florets. Flexner-Winter-Steiner rosettes signify moderate differentiation towards retinal tissue. It is a characteristic of retinoblastoma and is rarely found in other neuroblastic tumors. In Flexner-Winter-Steiner rosettes, there is a single row of radially arranged columnar tumor cells with peripherally located basophilic nuclei. The center of the rosette has a lumen lined with a membrane representing the external limiting membrane. Homer-Wright rosettes represent less differentiation towards retinal tissue as compared to Flexner-Winter-Steiner rosettes. In addition to retinoblastoma, Homer-Wright rosettes are also found in other neuroblastic tumors such as neuroblastoma and medulloblastoma. In the center of the Homer-Wright rosette, instead of a lumen, we find an eosinophilic tangle of neurofibrils. Florets represent more differentiation towards retinal tissue as compared to Flexner-Winter-Steiner rosettes. In florets, we find curvilinear arrangement of tumor cells demonstrating rod and cone inner segments attached to abortive outer segments. However, in a typical retinoblastoma specimen, Undifferentiated cells far outnumber rosettes or florets, and the extent of retinal differentiation of the tumor cells does not determine the prognosis for the patient, and it is important to remember. Immunohistochemically, the tumor stains positively for neuron-specific enolase, rhodopsin, S100 protein, and interphotoreceptor retinoid binding protein. Primary aim of treatment of retinoblastoma is preservation of the life of the patient, followed by preservation of the globe. Then comes preservation of vision if at all possible. If the disease is detected at an intraocular stage, there is 95% chance of survival for the patient. But if the disease is already extraocular at the time of detection, the chance of survival decreases significantly. Treatment of most retinoblastoma patients is multimodal, with globe-sparing chemotherapy, either systemic, intraarterial or intravitreal, globe-sparing local consolidation therapy with laser, cryo or plaque brachytherapy, or enucleation. Extraocular disease requires combination of high-dose multimodal chemotherapy, autologous bone marrow transplantation, and external beam radiation therapy. Enucleation is considered as a definitive therapy for unilateral disease with optic nerve involvement when the tumor appears to be apparently resectable with clear margins of the prospective level of optic nerve section. Enucleation is also considered for eyes with neovascular glaucoma, anterior segment involvement with the tumor, and with a poor visual prognosis. Enucleation is also considered for patients with persistence or recurrence of tumor following globe salvage therapy with chemotherapy or local consolidation therapy. In the IIRC system, Group E patients, most of whom have these signs, are considered for enucleation. We have discussed the techniques of enucleation in the oculoplasty section, and principles of enucleation for retinoblastoma include avoiding enucleating the wrong eye, which is disastrous and has happened, avoiding globe perforation, removing as long a segment of optic nerve as possible, typically more than 10 millimeters, orbital volume replacement following removal of the globe so as to promote symmetrical growth of both the orbits, and adjuvant chemotherapy and brachytherapy if histopathology of the removed tumor shows involvement of the cut section of the optic nerve. Chemotherapy is presently considered as the cornerstone of any globe salvaging protocol, and chemotherapy can be administered intravenously, intraarterially, or intravitreally. Systemic intravenous chemotherapy is considered highly effective for tumors in A, B, and C groups of the IIRC classification system, that is, tumors either having focal vitreous or subretinal seeding or are at an earlier stage. However, success rate of systemic intravenous chemotherapy drops to 50% for tumors in groups D and E, that is, tumors either having diffuse vitreous or subretinal seeding or are at a more advanced stage. In most retinoblastoma patients, chemotherapy must be combined with local consolidation therapy with laser, cryo, or brachytherapy, and 3 to 6 cycles of vincristine, carboplatin, and etoposide are given, the side effects of which include cytopenia, ototoxicity, and acute myelogenous leukemia. Local intraarterial chemotherapy is considered to be highly effective with more than 90% success rate when administered as an initial treatment for patients with advanced group D disease, that is, patients with diffuse vitreous and subretinal seeding. However, when used as a second-line treatment after initial treatment failure or recurrence of the tumor, the success rate of intraarterial chemotherapy drops to 50%. For intraarterial chemotherapy, the ophthalmic artery is cannulated from the femoral artery, and 3 cycles of melphalan, topotecan, or carboplatin are given. Intraarterial chemotherapy is restricted to children more than 3 to 6 months of age and or are at least 6 kilos. Side effects of intraarterial chemotherapy include periorbital erythema and edema, stroke, and a 3% per injection risk of ophthalmic vascular events including retinal non-perfusion, choroidal non-perfusion, vitreous and subretinal hemorrhages, and retinal venous occlusions. Intravitreal chemotherapy is considered to be highly effective adjuvant therapy for vitreous seeding. So it is never given alone but is combined with systemic chemotherapy, and usually 3 to 6 intravitreal injections of melphalan or topotecan are given. For intravitreal chemotherapy, safety precautions are mandatory to prevent extraocular spread of the tumor through the injection site, and the recommendations are a pre-injection ultrasound biomicroscopy to identify a tumor-free region for administering the injection, anterior chamber paracentesis immediately before administering the injection to reduce intraocular pressure, and immediate cryotherapy at the injection site after withdrawing the needle for injection. If any complications of intravitreal injection such as cataract, retinal detachment or endophthalmitis occur, the eye will require enucleation. Appearance of a retinoblastoma tumor which has regressed following chemotherapy belong to one of the 4 types. In type 1, we will find a white calcified mass which is also called a cottage cheese pattern of regression. In type 2, there will be a translucent grey non-calcified mass also called a fish flesh pattern of regression, and this type of regressed tumor may resemble an active tumor. In type 3 regression, there is a combination of types 1 and 2, and in type 4 regression, there will be a flat atrophic scar as seen in this photograph. In this photograph, we find a type 4 regression but only partially with active residual tumor. Local consolidation therapy for retinoblastoma includes laser, cryo, brachytherapy and external beam radiation therapy. Indications for laser therapy include primary treatment for small group A tumors and adjuvant treatment for tumors which have been reduced in size after chemotherapy. Unlike cryo, posterior tumors can be accessed and treated by laser, and an 810 nanometer laser or a 532 nanometer laser is used to photocoagulate the tumor. Multiple treatment sessions are usually required for a tumor, and complications of laser treatment include iris atrophy, cataract, vitreous seeding, fibrosis and retinal traction. Indications for cryotherapy is primary or adjuvant treatment of peripheral tumors with apical thickness less than 3 mm, and a triple freeze-thaw technique is used. In a freeze-thaw technique, the tissue adjacent to the cryoprobe is frozen and is then allowed to melt spontaneously, and in a triple freeze-thaw technique, this cycle is repeated 3 times. Adverse effects of cryotherapy include retinal tears and retinal detachment. Brachytherapy is administered with radioactive plugs, usually of iodine 125 or ruthenium 106. Indications of brachytherapy for retinoblastoma include primary treatment for tumors less than 16 mm in basal diameter and less than 8 mm in apical thickness, or a salvage therapy for tumors which have failed to respond to other globe-sparing therapeutic modalities. Intraoperative ultrasound guided localization of the tumor and placement of the radioactive plug helps in better local tumor control. And when compared with external beam radiation therapy, adverse effects of brachytherapy are higher rates of radiation retinopathy and optic neuropathy, but lower rates of radiation-induced cancers. Currently, external beam radiotherapy is used very infrequently and only when chemotherapy fails to cure the tumor in the only remaining eye, and particularly when the eye demonstrates extraocular spread of the tumor. This is because of the side effects of EBRT, which include orbital and mid-face hypoplasia and radiation-induced cataract, retinopathy and optic neuropathy. Even more importantly, bilateral multifocal retinoblastoma patients who are genetically predisposed towards developing cancers have a significant increase in the risk of developing second primary non-ocular tumors later in life if they have been exposed to radiation therapy earlier in life. And this is particularly high in patients who have been treated with EBRT before 12 months of age, which is the mean age of presentation of bilateral retinoblastoma. To summarize, initial treatment recommendations for retinoblastoma are as follows. Eyes with advanced unilateral tumor belonging to groups D and E of IIRC system in non-familial retinoblastoma cases should be enucleated. Advanced unilateral or bilateral tumors in bilateral or familial retinoblastoma cases should be treated with chemotherapy, either systemic or intraarterial. Early tumors in groups A or B can be treated with cryotherapy for peripheral tumors, laser therapy for posterior tumors, or brachytherapy. Intravitreal chemotherapy is highly effective for vitreous seeding, but as we have discussed, intravitreal chemotherapy is only an adjuvant therapy and so must be combined with other modalities for treating the primary tumor. Trilateral retinoblastoma with a pinealoblastoma should undergo excision or radiation therapy of the pinealoblastoma along with intensive systemic chemotherapy, often followed by bone marrow transplantation. For optic nerve and orbit invasion, systemic chemotherapy should be instituted, followed by enucleation with either debridement or EBRT of the residual orbital tumor. For intracranial metastasis, intrathecal chemotherapy can be administered, and intracranial and distant metastasis should be treated with intensive systemic chemotherapy, followed by bone marrow transplantation. Spontaneous regression of a tumor refers to its regression despite receiving no treatment. Rarely, large retinoblastoma tumors may undergo necrosis, leading to partial to complete spontaneous regression. This typically results in phthisis with or without vitreous hemorrhage and lens dislocation. So retinoblastoma should be considered in any young child presenting with non-traumatic unilateral phthisis. If calcification is detected on ultrasonography, it suggests retinoblastoma in any young child presenting with non-traumatic phthisis, and this phthysical eye should be enucleated. Certain tumors occur more frequently in patients with retinoblastoma, and these include retinocytoma, primitive neuroectodermal tumors, and second non-ocular primaries. Retinocytomas appears as a mass which is partly calcified and partly grayish to pink translucent in color. Typically, feeder vessels are absent and there is a limited area of chorioretinal atrophy surrounding the tumor. Absence of feeder vessels and presence of chorioretinal atrophy helps in differentiating retinocytoma from an active retinoblastoma tumor. Retinocytomas are clinically and histologically benign, but retinocytoma tumors carry mutations in both alleles of the RB1 gene, so they have the same hereditary implications as retinoblastoma. Rarely, retinocytomas may transform into an active retinoblastoma tumor later in life, giving rise to the rare entity of adult-onset retinoblastoma. Primitive neuroectodermal tumors or PNETs occur in 5 to 15% of patients with hereditary or familial retinoblastoma. PNETs occur in the pineal gland or the paracellar region and are termed as pinealoblastoma, and they occur as part of trilateral retinoblastoma. Trilateral retinoblastoma constitutes of bilateral intraocular retinoblastoma with a pinealoblastoma. Normally, the pineal gland shows evidence of containing photoreceptors from where the PNET arises. PNETs usually occur months to years after treatment of the intraocular retinoblastoma, but can rarely occur prior to the onset of the intraocular retinoblastoma. Primitive neuroectodermal tumors are considered as a separate primary tumor and not as an intracranial metastasis of the intraocular retinoblastoma, and this is very important to understand. PNETs are usually well differentiated, showing Flexner-Winter-Steiner rosettes, and they usually do not metastasize, but they still have a poor prognosis and are treated with a multimodal approach, as we have already discussed. Second, non-ocular primary tumors, so they are primary tumors occurring elsewhere other than the eye, occur in bilateral or hereditary retinoblastoma patients who are genetically predisposed towards cancer development. The risk of these non-ocular primary tumors developing in these patients is 1% per year, and this risk increases by twofold if the patient receives EBRT for the retinoblastoma. The mean latency of these non-ocular primary tumors developing is 9 years from the treatment of the retinoblastoma. Most common among these tumors is osteosarcoma, which is important to remember, and other such tumors include soft tissue sarcoma, cutaneous melanoma, PNETs, and other brain tumors. In patients who develop these second non-ocular primary tumors, the 5-year survival rate is poor, being less than 50%. And so considerations for prophylaxis and surveillance is important in patients who have bilateral and hereditary retinoblastoma, and these include avoiding smoking, avoiding radiation exposure, using sunscreens, awareness about possible symptoms and signs of these tumors, annual physical examination, and whole body imaging with MRI to detect these tumors early on. With the advent of chemotherapy, more than 95% of patients presenting with intraocular retinoblastoma survive. But according to the Children Oncology Group, with multimodal treatment with high-dose chemotherapy, radiation therapy and bone marrow transplantation, the 3-year survival rates are 87% for patients with regional extraocular tumor spread, 79% for patients with non-CNS metastasis, but only 8% for patients with CNS metastasis. So CNS metastasis from retinoblastoma has the poorest prognosis, as we had mentioned earlier. Histologically, risk of metastatic disease increases with optic nerve involvement, particularly at the level of transection of the optic nerve, and this is considered to be the most important risk factor for metastatic disease. Massive choroidal invasion, defined as choroidal invasion of more than 3 mm diameter in any dimension and reaching at least up to the inner surface of the sclera, is also considered to be a risk factor for metastatic disease, and so is histological evidence of extrascleral extension. Surveillance recommendations for patients with germline or bilateral disease are as follows: every 4 weeks till 6 months of age, every 8 weeks from 6 months to 3 years of age, every 3 to 6 months from 3 years to 7 years of age, and annually from 7 years to 10 years of age, followed by every 2 years from 10 years of age onwards. And surveillance recommendation for patients with unilateral disease with a somatic mutation are every 3 to 6 months till 7 years of age, and every 2 years from 7 years of age onwards. Siblings and offsprings of retinoblastoma patients with germline or bilateral disease should be monitored closely till 7 years and infrequently thereafter if genetic diagnosis is not performed. To recap, retinoblastoma is the most common primary intraocular malignancy in children, sporadic cases with germline mutation, and familial cases present earlier in life have multiple and bilateral tumors in the eyes, are predisposed to second non-ocular primary tumors, and pass on their genetic trait to their offspring. In the early stage, retinoblastoma presents with leukocoria and strabismus. In later stages, it presents with proptosis and signs of orbital inflammation. There are two types of growth pattern of retinoblastoma. One is the endophytic, which can have vitreous seeding, and the other is the exophytic, which can have subretinal seeding. Larger tumors have both endophytic and exophytic components. Trilateral retinoblastoma is the occurrence of a pinealoblastoma in patients with bilateral retinoblastoma. Pinealoblastoma is a primary tumor and it is not a metastasis from the ocular retinoblastoma. Brain is the most common site of metastasis and also the site with the poorest prognosis. USG-B scan typically shows calcification, which is almost pathognomonic of retinoblastoma. EUA is mandatory in all patients suspected of having retinoblastoma. FNAB is contraindicated in retinoblastoma. IIRC classification is the system most commonly used presently and is based on size and location of the primary tumor, vitreous and subretinal seeding, and subretinal fluid surrounding the base of the tumor. Histopathological evidence of differentiation of the tumor cells towards photoreceptor does not determine prognosis. The primary aim of treatment of retinoblastoma is preserving the life of a patient, followed by preservation of globe and then preservation of vision. Enucleation is recommended for patients with advanced unilateral disease, and a long stalk of the optic nerve at least 10 mm must be included with the enucleated globe. Chemotherapy is presently the cornerstone of globe-preserving therapy for patients with bilateral advanced retinoblastoma, and it should always be combined with local consolidation therapy. For very small early tumors, Local consolidation therapy in the form of cryo, laser, or brachytherapy can be used alone. Metastatic disease requires high-dose intensive chemotherapy and bone marrow transplantation, often with radiation therapy to the site of metastasis. Patients with familial disease and germline mutation, as well as patients with somatic mutation, should be under long-term surveillance. Patients with familial disease and germline mutation require surveillance for recurrence of treated tumors, occurrence of new retinoblastoma tumors, and occurrence of second non-ocular primary tumors. Patients with somatic mutation require surveillance for recurrence of treated tumors. External beam radiation therapy is no longer the primary therapeutic modality for retinoblastoma because of radiation-induced side effects, including increased incidence of second non-ocular primary tumors, which are the most concerning. Poor prognostic factors include metastasis, particularly CNS metastasis, pinealoblastoma, and occurrence of second non-ocular primary tumors. Histopathological markers for increased risk of metastatic disease include evidence of involvement at the cut section of the optic nerve, massive choroidal invasion, and extraocular or extrascleral extension. It has been a long topic, and thank you for listening.